Hi, I'm Dr. Joe Roberson. Welcome to this video. Our purpose in this effort is to show you the end from the beginning. What I want you to see is a very comprehensive view of the entire process and the alternatives, the evaluation methods, and the treatment schemes for people that have atresia and microtia. I deal with hearing, and my purpose is to provide hearing for your child. Let's talk about it. Hi, I'm Dr. Joe Roberson, and I'm going to speak to you over the next roughly 1 hour regarding congenital oral atresia and development. What I'd like you to understand when we finish is the process that we use to go about evaluation, what the options are for treatment, and what the impacts are with and without treatment on your child and those that you know may have this condition. I live in Palo Alto, California. That's in the San Francisco Bay Area next to Stanford University. And it's there that I have practiced my craft at the International Center for Atresia and Microtia Reconstruction. This is our building in Palo Alto, California, near San Francisco. I have trained extensively to become a neurotologist and a skull-base surgeon. Originally, that included training at the University of North Carolina, as well as Stanford University, and then a fellowship in Los Angeles for a year, and then also a self-arranged fellowship in Europe. When I finished my training in 1994, I came back to Stanford as the director of the otology, neurotology, and skull-base program, where I stayed for 10 years. And in 2004, due to impending changes in medicine in the United States, left Stanford and started the California Institute Medical Group, which is a private practice in Palo Alto, California. We have there, has developed the International Center for Atresia and Microtia Repair. This has been the third area that I've targeted in my career. It's an intentional target. That's the last one that I've worked on. The other two being cochlear implants, which is an implantable device for children who are deaf and also for adults, and a type of brain tumor that affects the hearing nerve called an acoustic neuroma. And over the last 15 or so years, we've developed a very large experience. The information that you're going to hear today comes from our presentations around the world. It's been refined in over 120 conferences in a number of different countries, as you see here. And more importantly, it comes from our experience with evaluating over 5,000 patients with this condition and operating on patients, about 3,000 or a little over 3,000 now, from 60 different countries. So we have quite the breadth of knowledge, and what I hope to share with you is my perspective on that process and how to go about this for your family. Let me introduce you first to my family, and these young and wonderful people have been in my home for quite a while now. And what I'd like to share with you is that I will talk to you today both as a scientist or a medical professional. We'll give you the data and the objective information, make good decisions, but also will speak to you as a father, because what I think is best is for me to couple those two with an understanding of what we want for our children and what they really deserve. So in this photo here, to my right in the orange is my oldest daughter, Caitlin. Caitlin's 34 and works in business in the San Francisco Bay Area. My wife, Julia, of 36 years. My youngest in the middle there is Haley. Haley is a physician's assistant, and she actually works with me in the California Ear Institute. Next to her in the gray t-shirt is my son, Baxter, a middle child. And next to him is his wife, Margaret, who he's been married to for about 1.5 years now. So that's those are the Robersons. Now, here's what we're going to cover. Pardon me. We cover hearing. We'll talk about development and how hearing impacts that and the human condition. We will go about showing you how we evaluate children. We'll talk about the treatment options and then results. So first of all, the condition itself is called congenital oral atresia and microtia. Atresia is the component that involves the ear canal and the eardrum and sometimes the middle ear bones, whereas microtia is the component that involves the outer ear. Now, interestingly, we will usually see these two together. Both the outer ear and the ear canal are malformed. Sometimes we'll see an outer ear that's normal and then a malformed ear canal, but we never see a condition where there is the opposite, where there is no outer ear but a normal ear canal for some reason. So congenital oral atresia and microtia is what we're talking about here today. So hearing has several components, the first of which is the outer ear here that focuses sound down the ear canal. The ear canal allows the sound to contact the living, very delicate and thin membrane, the tympanic membrane or the eardrum. The eardrum then ensues or is connected to the middle ear bones where vibrations are transmitted and amplified to the inner ear. The fluid of the inner ear contains nerve endings called hair cells that will return or turn that vibrational energy into an electrical energy, and then that signal is sent to the brain through the hearing nerve. So in this diagram here, this small video, you'll see as I'm speaking to you, the sound is coming down the ear canal, striking the red eardrum, the middle ear bones move, the inner ear and the snail-shaped cochlea receives the sound, and then that sound is sent along to the brain itself. There are about 10,000 fibers, and it's very complex in terms of the signal that gets to the brain. Now, it's very important for you to notice also that the brain has a large number of connections from the hearing nerve. I think that's important because that has a lot to do with how important hearing is for brain development. And we'll talk a little bit more about that here in this next section. So here are some slides, or some pictures, if you will, of very early embryo development. In the top left, you see at 22 days of age, there's a ball of cells. There's a little fuchsia circle around it, where a pit develops, and this ball of cells develops into the inner ear. Now, the inner ear is formed very early in development. If you think about it, at 22 days after conception, you probably don't even know or maybe even suspect that you're pregnant yet. So that forms, as you see in the bottom right, the cochlea and the semicircular canals, which are the balance component of the inner ear. Next, we'll see the ear canal develop. And bottom left, you see a small pit where the canal starts. The canal dissolves away, and the bone of the base of skull dissolves around it. It becomes skin lined, and then that stops at the eardrum, leaving a thin tissue membrane layer. An identical process happens at the same time from the back of the throat, where a similar bud forms, and then that airspace forms around the middle ear bones. The middle ear bones are left in place. They don't dissolve, but the other tissues do. And what happens after that period of time is we now have access for vibrational sound to come into the ear. So the portion that is malformed with atresia, you see here in the red, is affected early in development. So by 32 to even 35 days, that's completely formed. Next is the outer ear. And as you see in this diagram in the bottom right, there are 6, we call them hillocks. They're tissue bumps or rises that form, they mold, they twist, and come together around the ear canal. And that ear forms at about 40 to 52 days, and then it is completely formed by the child is 2 months post-conception. You can see in the picture just above the 40-day image there, if you look carefully above the numbers 1, 2, 3, 4, 5, and 6, you can see an eye that's developing, and just to the left of that, you can see a mouth and a nose. So the ear is fully formed sometimes before, as I say, you know that you're even carrying a child. There's several varieties. Most of the time it's complete, which means that the whole ear canal is missing. And most of the time it is single-sided. 90% of the time it's just one ear. Right ears are involved more than left ears, and boys are involved more than girls for some unknown reason at this point. We see complete bilateral atresia where the condition is present in both sides in about 10% of cases. And by the way, if that's the case with your child, it's very important to provide amplification or hearing stimulus early in life. There's a device that a headband is used to hold a vibrating hearing aid against the skull that can stimulate the inner ear. If that's your case and you haven't done that yet, then contact us and we'll show you how to get that done. We can also see a partial formation of the ear canal. In essence, what happens is the pit starts, the ear canal begins to dissolve and to open up, but it stops somewhere in the process. So you get either a short ear canal, sometimes you get a normal length ear canal, but it's very small or thin. Sometimes the eardrum doesn't develop fully, but those are also about 5% or a little less overall. They're rare, but those are present as well. We see something called hemifacial microsomia, which is involvement of the jaw and also the upper jaw, called the maxilla, the bony structure of the face, and the soft tissue of the face in about 23% of our cases around the world. And what you'll see is an asymmetry. When you look at a person with hemifacial microsomia, you'll see that one side is not as large or as developed as the other side. Most of those are relatively mild and don't require treatment. Sometimes severe treatment, severe malformations do require treatment, and there are physicians in our office who have pioneered many of the means of treating hemifacial microsomia, and we'll talk to you about that if we have individual appointments, either in a conference or by video teleconferencing to our office. Now, this next concept is one of auditory development, and I taught a course at Stanford University regarding auditory development that was a semester long, and I'm going to boil it down to one slide for you here. So it's the important concept that I want you to get, because it's important to know this data, to know when to time the correction of the hearing deficit associated with atresia. And what happens with us as adults is, or as formed neonates growing into adults, is that when we're in utero, our hearing system is formed. The nerves are actually functional. Many of you women who have been pregnant know in your third trimester the baby can hear you. When you speak or when a loud noise happens, sometimes they'll jump or startle, and you can tell that hearing is getting through. So when a child is born, the hearing system actually is receiving, processing, and taking sound to the brain. What hasn't happened yet is that the very complex nerve connections that you saw in a previous slide have not formed completely. That happens when sound waters the system. If you think of this as a seed, for this hearing system to grow into a fully formed and beautiful plant, it has to have sound to go through it for it to become what it's supposed to be. In the first 3 years, as that sound comes in, you speak to your children, they live in a hearing world, receptive language develops first. And that means that children will understand spoken language before they're able to speak. For example, you may have had the experience that I've had, and when my children were 1 year old and they couldn't say to me, "Can I have a cookie?" If I asked them if they would like to have a cookie, they knew exactly what I was talking about and would walk to the cookie jar, or it was clear they knew what was happening. So the receptive language is in the first 3 years, and that's a very dense learning period. Expressive language overlaps that, and expressive language is the ability to have spoken language. Most children 10 or 12 months of age begin with a few words, and then by 18 months of age, they're starting to put 2- and 3-word phrases together. And by 5 years of age, they have roughly 5,000 words of vocabulary. So imagine that. That's a lot of learning for the little guys that we know and love to go through. That's followed also, or an overlap slightly, with more complex functions. And as you'll see, the complex functions are the ones that are the most impacted when you have a hearing impairment. And those complex functions go up to about 10 years of age, where their major development occurs. So during that period, the bottom line is that you have to stimulate the system with an impulse of some type. In this situation, it's the auditory system, so it's hearing, in order for it to develop fully. That's really the definition of a medical term called the critical period. And a critical period is that time wherein you have to stimulate a system. Now, if you don't stimulate the system within that time period, that system almost loses the ability to change and to mature fully. And I'll give you one example that makes sense to people, is that I'm from the United States. I grew up in the southern United States, and people in the southern United States have a distinct accent. Maybe in your country there are certain regions that do as well. So once you get to 10 or 12 years of age, that accent is really set. It's very hard, if not impossible, for you to change the way that you speak over time. You can soften it a bit, but you'll still hear it coming through. And that's an example of that critical period. Sometimes people will call it an imprinting period, but a critical period where I heard spoken language, Southern spoken language, and I mimicked that. So there are other examples. For example, if you know of a child that has a lazy eye, an eye that isn't quite focused in the right place or direction, if that eye is not corrected and surgery done to make the eye focus on the right thing, the brain will actually ignore that eye completely. So later in life, if you try to correct it, you can realign the eye, but there is no signal that the brain uses from that side. Now here's a question for us, is why do we have two ears? It's a good question. There are several possible answers. One is maybe a backup is good. That's certainly one positive reason. But there are more significant ones than that, is that there are two ears, they are needed actually for specific functions, important functions. And the most important one that we see is what is called binaural hearing, or hearing in noise. And let me explain that to you. When we are in, let's envision a complex sound environment, maybe a restaurant where it's getting very busy on a Saturday night. Our ears are bombarded with sound from the kitchen and from tables next door and from the plates and forks and the air conditioning and the spoken language that we're trying to listen to. Our brain is the portion of our system that filters out the unwanted sound and allows us to focus on the sound we are trying to hear, spoken language. For that to work correctly, the brain has to have input from two ears. So what happens, is the brain filters the conversation next door, gets rid of the conversation in the kitchen, the noise from machinery next door, etc., and you begin to understand how or what the person across from you is saying. Now, we've all had the experience of when that background noise starts getting really high, it begins to be hard to understand the person who's speaking to us, and that can get quite annoying. Well, in normal hearing individuals, if you're in a restaurant and when it's getting really loud and it's hard to understand, your understanding is dropping from 100% in quiet to about 90 or 95%. And as I say, that can be quite annoying. If you have a single-sided hearing individual, it drops from 100% in quiet to about 60% in that same noisy environment. So it can be absolutely maddening for people. What happens is that in school, for example, children will become they just detach. They just go, I can't do this, and they stop paying attention. Sometimes there'll be a behavior problem and they become angry. It seems to happen a little more with boys. And what we've seen statistically is when we look at people who go through school with a single hearing ear, they're 1,000% more likely, 10 times more likely to repeat a grade. And there is no doubt that single-sided hearing has an impact on a child. Now, sometimes children are very intelligent and they can take that hit and still do quite well. But if you want the best for your child, two-ear hearing is absolutely the way to go. And I would also point to one other statistic that in the United States, when we look at average income of people with a single hearing ear, it is on average 1/3 less than people who have two hearing ears. So it does have an effect on people. If you like to read articles, here's a good one for you from Science in July of 2012 that looks at vocabulary and its correlation to income. And if you look at the multicolored bars, on the left side, the vocabulary score of 0 to 4, which is a low score, the average income you see is between $20,000 and $30,000, whereas a very developed vocabulary to the right side under the bars at the level of 10 is quite a bit more than that, between $50,000 and $60,000. So in our development, the most important thing by far for language and vocabulary development is hearing. Now, it's important for children to be read to use spoken language, to be in a verbal environment, of course, but if you don't have hearing, none of that other works. So it's very important to do that. Another one that I'll mention is something called sound localization. And imagine yourself on a soccer pitch or a football pitch, and someone calls to you and says, pass the ball to me, I'm open. In a normally functioning system, you know where that person is. You can tell where they're calling you from. That also requires two ears. So if you have a single ear, you'll hear that person calling you, but you won't be able to tell where they are. And you may have seen your children who experience that. Let's say they're at a mall and you call to them, that they'll scan around trying to find you, but they're not able to tell exactly where you're coming from. With two ears, we have a very developed ability to tell where a sound is coming from. And perhaps that's a safety factor for us, because we do see children with one hearing ear go to the emergency room about 20 times more frequently than children who don't. And we think that's due to, for example, imagine a bicycle coming at you from behind and you can't quite tell where that sound is coming from. It can be quite dangerous. So all of that to say is we've been talking about this for a long time, but more recently medicine has caught up and started to understand this. And I'll read this first quote, that recent studies have shown another alarming phenomena. Long-term hearing deficits may remain after asymmetric hearing loss has been treated if the correction was not completed within a critical time window. Now, you should understand historically that in the beginning of my career, we treated the hearing component of this condition after we treated the outer ear. We used a technique for the outer ear repair, the microtia repair, called rib graft surgery, where that went first. It needed to be for the blood supply and for that technique to work, and then the ear canal was done. Our average repair of ear canals when I performed surgery that way was 12.8 years. Now, with your new knowledge, how does that work for development? Right? You understand now that that's the wrong way to do things. So what we've done is that we have flipped that or switched that around. I'll show you that more in just a minute. And we're the first group to do that. And it's beginning to be clear in our data now, after we've done it for about 15 years, that patients who had hearing restored early in life have completely different functional ability. In fact, frequently and usually normal ability with things like hearing in noise and directional sound, whereas patients who had hearing restored later in life, they've improved, but they haven't come back to normal completely. So in this first portion, what I want you to understand, these are the take-home points here in the next two slides, is first of all that really development and brain development is what we're talking about, is sound dependent during the critical period of childhood development. First 5 years are the best, first 10 years are the target. And I also want you to understand that normal function requires 2 ears. There are people all around the world that constantly that we see in these conferences who say to me, my doctor said not to worry about this, that there's no problem with it. Well, those doctors are wrong. They're not intentionally wrong, but they're just uneducated. And one mistake they make is that in quiet, you'll watch a child function and listen with a single hearing ear, and they'll appear normal. It's when the noise and more difficult situations come in that you start to see the problems. And what I want you to understand, this is very important, is that we have to repair that system before the real deficits actually show up. I have heartbroken parents who come to me with a child in 7th or 8th or 9th grade in their mid or early teens, and they say they just cannot keep up with school. We need to have this ear fixed. We can do that, and it improves things. But if they've had the ear repaired at 3 or 4 or 5, we never would have gotten into that situation, and we would be able to function normally. So that's a really important take-home for you. Early hearing, best results, and as we've stressed already, if we miss that early window, then it's a lost opportunity. So our goal, if you will, is to provide the best option for hearing to every ear, and there's almost always an option for each ear to hear. And it's really not a question of if, it's a question of how. So let's go on and talk about how we do that now. So the evaluation of people with atresia microtia was just atrocious when I first started this focused area of intent. You just couldn't tell how people made this decision, and you couldn't compare treatment groups because you didn't know how they were selected or what their preoperative data was. So the first thing, or one of the first things that we did, was put together a classification system. And here's the paper that I wrote that was published on that subject in 2013. And it uses a system, an acronym, HEAR maps, to make sure that we go through a systematized evaluation for each child that allows us to predict what chance of success we would have for different combinations of HEAR map scores. And it also allows us to evaluate our treatments looking back to see which ones we should improve or which ones are good or which ones maybe we shouldn't do. So here's the scheme. It's not critical for you to memorize this, but I just want you to have some familiarity with it. And the first one is hear, or hearing. That's based on an audiogram. I'm going to show you a hearing test in a minute. It tells us what function the inner ear has and what the child's actually hearing. The E is for ear, and that shows the form of the outer ear. Dr. Reinisch will show you his grading system. There are 4 different grades that we use. The A is based on an X-ray called a CT scan. And what we have is a 10-point scale that we give points for individual components of the ear that are present. For example, the middle ear bones have points associated with them. The inner ear has points associated with them. Whether there's enough space to make the canal, etc. And again, I'll show you that in just a minute. R is for the remnant lobe or the lobule where you would pierce the ear. That's always malpositioned, but it's usually pretty normal in size. M is the mandible or jaw. Is that normal compared to the other side, or does the patient perhaps have hemifacial microsomia? A is the soft tissue of the face, the cheek. Is that symmetric side to side? P is the facial nerve, and the facial nerve is one of 12 cranial nerves. It's the 7th cranial nerve that runs through the ear, and it affects or brings about motion on the side of the face of that ear. It doesn't have anything to do with sensation, but the movement of the face. And if the facial nerve is abnormal, frequently there will be poor outcomes with surgery. And so that's a correlating factor for us. And last is there a syndrome? There are a number of syndromes, and that's increasing all the time, where a genetic abnormality can cause the ear condition. It's important to look for those because frequently, if you do have one of those or your child does have one of those syndromes, then we need to look at other organ systems, for example, the heart or the kidneys or the spine that can have abnormalities that we need to make sure are treated or make sure that we know about those for obvious reasons. So of the HearMap scoring system, there are really two different areas that require a test or objective data, as we say. And one is the hearing, which is an audiogram, and the second is a CT scan for the Atresia component. I'll show you those in just a second, but you have this brochure, which if you're in a conference has been handed out to you, and if not, we can mail that to you as a quick reminder of what data we want to see to be able to evaluate your child. Now, we do these in consultations in conferences, as you saw, all around the world, and we also do these in video conferences where patients send this data to us from around the world constantly, so we can help in either condition there. So this is a hearing test. And what we do is we place a vibrating device against the bone. That vibration is transmitted through the bone directly to the inner ear, to the cochlea, and in the cochlea it is received. So on the diagram you see in the bottom right, under audiogram, on the vertical lines you see different frequencies. So 250 and 500 hertz are on the left side of the graph. That corresponds to a subwoofer. If you've ever been at a traffic light and someone is playing, let's say, rap music next to you and the subwoofer is going, you can kind of feel it almost as much as you can hear it. That's the spectrum of sound on that side. And to the right is a high-frequency sound, 4,000 hertz, where very high-pitched watch beeps will be heard, or very high-pitched sounds of any type. Speech typically falls from 500 to 4,000 or 3,000 hertz. And, in this situation, the hearing is normal. The gray area of the graph is normal. So it tells us that the receptive capacity of the cochlea is present and normal. You can think of that as the potential for the ear. The second portion of the hearing test is that we bring sound in from the outside. We put, for example, a headphone over the ear, and then we present sound to the child. In a normal ear, the red and green lines are right on top of one another. But in an atresia ear, the sound has to be very loud to be transmitted to the inner ear. It can be transmitted to the inner ear. You may know that if you get really close to a child's ear who has atresia microtia and you speak at a reasonable volume, they can hear you, usually in that ear. And that's, in this example, is what's happening. You see there's no ear canal, although there's a normal inner ear. And we have a large, what we call air bone gap. The bone is the testing of the inner ear hearing nerve, and the air is the testing of the outer ear. Now, to give you some perspective, if you put your finger in your ear, that yellow line is about where your hearing would be. So the amount of hearing loss that's present with atresia is very large. In the conversation I'm having with you now, I'm speaking at about 45 to 50 decibels. So in our conversation, an atresia ear would not be receiving any data or transmitting any data to the brain from spoken language. This is going to be an example of a CT scan, and this young fella has a normal left ear, and he has a classic right-sided grade 3 atresia microtia. So he has malformation of the ear canal and the outer ear. And we can remove the soft tissue with computer algorithms to show what the surface of the bone looks like. And if you see the red arrow in the bottom right, you can see an open ear canal, whereas on the left side there's no similar component at all. Nothing developed. And if we look at that scan with slices, like almost like bread loaf slices through the base of the skull, and we do that every millimeter or two, and we look at a sequential section of slices, we can put together in our brain a 3D picture of what the inner ear looks like, which you can't see, obviously, from the outside. In this example, as you're looking at the board, the normal side, which is your right side, you see black is air, and there's an opening in the bone that comes down toward the more dense white bone of the inner ear, in that area here. Now, the other side, you see there's no opening. It's just solid bone. The inner ear is present. There are middle ear bones present. And as we go up and down in level through that scan sequence, then we apply our grading system. And here is that. Not critical that you know it, but just to know there are 10 points. For example, the outer ear gets 1 point. If that's malformed, then 9 is the highest score that you could get. And then as you look down through the rest of the list, those are all structures of the inner ear. The mastoid tells us whether we have enough space for a canal. The round and oval windows and the stapes and the incus and malleus are all parts of the sound conducting mechanism to the inner ear. And interestingly, too, we always look for the facial nerve course because that's an important thing that we want to preserve and not injure. And more about that in a little bit. So those patients who have a CT read, and by the way, I demand that I read every one of them. I don't want someone else to give a grade because I just found that the person that's considering doing the surgery needs to be the one that looks at that scan. Here's the scheme that I apply, is that if you have a score of 6 to 10, then it makes sense to do ear canal surgery and to open the canal to get hearing. If you have 4 or less, I don't think it does make sense, except in unusual circumstances, to open the ear canal, whereas a score of 5 is on the border between the two. Sometimes there are some 5s that are a little better than others, and if a patient has bilateral atresia and microtia, sometimes we'll do surgery for a patient with a 5, trying to get partial hearing, which can be very helpful with things like swimming or in the shower or when you're sleeping or those sorts of conditions. But mainly 6 to 10 is where we like to see in terms of the surgery. Now, there are 2 times where we have to do semi-urgent surgery. One of them is a condition called a cholesteatoma, which is actually a tumor that forms in the ear instead of the normal ear canal. And the second is if there's an infection and there is paralysis of the facial nerve as it goes through the inner ear, we have to drain that. By the way, it is possible for an ear without an ear canal to get an infection. This is an example of a HearMap score. This is a young man who has a maximum conductive hearing loss on the audiogram. He's H1.6. He has a grade 3 outer ear. The CT scan shows a score of 8. He has no asymmetry in the jaw, the midface. His lobule is normal. He has no paralysis and no syndrome. And below, you see his right ear after it has been repaired with a combined atresia microtia approach, and his hearing returned to the normal range. Now let's go on to treatment, and I'm going to go through some things that are important for you to understand as your care team. What we recommend is you have a pediatrician close to home. That's for medical evaluation, well child care, to look for syndromes, and to provide the day-to-day care. You want an audiologist who can test the hearing in your child, and by the way, pediatric audiologists, if you have a child with this condition, are very good at testing children, whereas some people are not comfortable testing kids. So we recommend you look for a pediatric audiologist if your child has this. An otologist is what I do to make hearing decisions and also advise regarding auditory and language and verbal development. Plastic surgeon reconstructs the outer ear, and then a craniofacial surgeon in some situations is used to reconstruct the jaw or facial abnormalities. Your first step in that process is testing the hearing. That can be done at birth, and you want to test both the affected ear and the unaffected ear. This is if your child has unilateral atresia microtia, because we've seen in the unaffected ear, 27% of the time there's a hearing loss. There can be an abnormality which is very small, and we want to know that because that can severely affect development. We want to look for a congenital syndrome. We have the most common 12 listed on our website. If you're concerned about those, your pediatrician or a developmental pediatrician that some countries have are specialists in looking for congenital syndromes. And in some cases, in most cases, it's good for us to use or to recommend the speech and language evaluation. And these professionals, speech and language pathologists, as they're called in most places, will give you a report card to tell you if your child's language is on course. Now, if this is your third or fourth child, you will naturally know whether they're behind or on track. But if it's your first child, it can be very hard for you to know. And I would recommend in that case specifically that you enlist a professional really to give you a report card every 6 months or a year. And are we making progress and are we doing the right thing? And then early consultation with the otologist is good. We recommend a CT scan at 2.5 years after the ear has grown some, in order to know whether they would be a candidate for surgical repair. So that's the earliest that we've done it. Sometimes people bring us scans at 5 days or 10 days of life, and it'll tell us whether the inner ear is present or not, but not much more than that because there's just not enough development yet to give a score. If you're a schematics kind of person, here's what that looks like. The CT scan at 2.5 years. If it's grade 1 through 5, then typically we do not recommend an ear canal, but we will recommend an implantable hearing device. And in grades 6 through 10, we will recommend an ear canal. So let's talk just a minute about the implantable devices so you know what those are about. And there are a number of these. What happens is that an implantable hearing device takes a sound from the environment, a microphone receives it, and then it transmits the sound to a vibrating device that transmits from the bone to the inner ear, just like the audiogram that we've done. And that signal transmits to both ears. That's not ear specific, so that's one of its downsides. But there are a number of offerings to do that. Here is one that's called the Bone Bridge, made by a company named Medel. And you see up behind the ear the external processor that attaches. There's a magnet that holds it in place. There's nothing in this device that comes through the skin. Here's another, Baja and Ponto, which has a transducer that is placed. This one is percutaneous, which means that there is a small post about the size of an eraser on a pencil that comes through the skin, and then the hearing aid connects to that. The device will, again, vibrate and transmit the sound energy through the bone to the inner ear. Here's another one called the Baja Attract, where a magnet is actually implanted and affixed to the bone. And then there's a magnet in the external device. So in this case, there's nothing coming through the skin. And the vibration is transmitted across the skin to the internal device and then stimulate the inner ear. So these are different companies, they're different devices, and there's slight differences between them, but they all use the same strategy. Let's also not forget hearing aids, because some children are very well served by having an ear canal made, and then if the hearing doesn't come up to normal range, we can place a device in the ear canal that increases the sound volume and gives them sound in that ear. That device, basically, its most large advantage is that it stimulates just the ear you put it in, whereas the Baja and the Ponto and the Vibrant Sound Bridge all stimulate both ears. So you don't get good hearing and noise, and you don't get directional sound with the bone conduction devices. So the hearing aid and canal is a little superior. I'll give you a hierarchy later in the talk as to what's best and how we go about that. Let's move on now to the canalplasty. That's opening or providing surgical repair of the canal. And what we do is that we remove the bone that's in place, so that sound can come into the ear, just like you saw earlier in the animation that I showed you. The pin actually has to do with sound, the high frequencies particularly, and the size and shape of the ear canal gives a certain resonance so that that vibrational energy can transmit through the lever action of the middle ear bones and receive stimulus to the inner ear. I mentioned this briefly, but let's make sure we have it, is that if you decide on the outer ear reconstruction method that you will use, that really predicates or determines what timing we have for the ear canal. If you decide to have a rib graft reconstruction of the outer ear, which is around the world the most common one that's used, it is typically started at about 5 or 6 years of age and has 3 or 4 procedures, and usually the earliest that we'll see a child is in 8 or 9, sometimes a little later than that. As I said earlier, our average was a little under 13 years of age. So you need to provide hearing to that ear during that time period you're having the outer ear reconstructed, and usually we do that with the device that wears a headband and shows a vibration against the skull. The second option is to have the reconstruction done with something called porous polyethylene. That's its chemical structure. There are some trade names. For example, MedPor is one. There's some others that will be used to reconstruct the outer ear. That's what Dr. Reinisch will talk to you about today, or talk to you about. The canal can be performed first as a single surgery. That takes about 2 hours. And then 6 months or more later, the outer ear can be reconstructed in a separate surgery, in a second surgery. The other option is to provide reconstruction of both the ear canal and the outer ear on the same day. This is a procedure, these last two are both procedures that we pioneered, called the combined Atresia microtia repair. And we'll talk about that one in a moment too. So this is, again, the paper, if you like to pull these and read them, in September of 2009, where published with our team, the Atresia repair going first. Instead of the outer ear happening and then the hearing being restored, we would restore the ear canal to normal form, bringing about hearing, and then later the outer ear is made and placed around it. So I'm going to show you some videos of the surgery so that you know exactly what this entails. And there are really 5 scenarios that we will perform ear canal surgery. The child needs to be 3 years of age. That's the earliest we do that. And we like to see 15 kilograms. Sometimes we'll go a little under that if we're doing just an ear canal, but 15 kilograms in 3 years is the ideal. The first scenario is a normally formed outer ear with no ear canal. Now, there is a syndrome, an 18q- syndrome is its name, where sometimes there's a genetic abnormality that's caused this. So if this is your child's situation, talk to me and we'll tell you or show you how to go about evaluation for that. Number 2 is after a rib graft, and this is a patient, Bert Brentz, who had a rib graft of the outer ear first and then followed that with an ear canal surgery. The third is surgery for the ear canal first and then the outer ear reconstruction second. And this is a young boy from about 12 or 13 years ago who had ear canal surgery. You see a picture of that with the pink sponge still in place with a little opening coming out behind his small ear. And then this is a picture of the combined surgery where we do both the ear canal and the outer ear in the same procedure. And that's patients go home the same day from that one. And then the fifth one, which we don't like to do, and we do not recommend it, is having the outer ear performed first and then the ear canal surgery. We've done it for some parents who didn't understand that they were canal candidates and hearing was a significant issue for their child. But the problem with this strategy is that there's a chance that we will lose the graft, the outer ear graft, after the ear canal is made. So that is not recommended, but sometimes it's one that we can do. We use several very important things for success in the operating room. Number 1 is a monitor that tracks the facial nerve. And what happens is there are small needle electrodes placed within the muscle of the face. And if the facial nerve is stimulated, if we're coming close to that and making the canal, it will cause the facial nerve to fire. The muscles of the face will twitch. The monitor turns that into a sound, an alarm sound, so it alerts the surgeon that you're getting close to that nerve. We also find that using the laser, as you'll see in a few minutes, is absolutely critical to sculpting the middle ear bones. They're always fixed to the surrounding bone. We have to free them. And a laser allows us to free them without transmitting energy, vibrational energy, to the inner ear. The other way is to drill that bone away, and that drill can actually injure the inner ear, so it's a safety issue. And this is a very important or very difficult surgery. It's very important for someone who is experienced with this to do the procedure. We get a lot of referrals for patients who've had a surgery and then we try to repair the surgery. And we can frequently get good results, but it is much less likely. The best chance is by far the first surgery. People ask us, how often does one surgery do that for the ear canal? And the answer is 94% of the time. Again, not everyone is a candidate, but if a child is a candidate, then 6% of the time we have to go back and do a second surgery. And most of the time, as you'll see in a few minutes, it's due to an abnormality of the middle ear bones that we don't repair at the first procedure. All right, so I'm going to show you a sequence from the operating room where you'll see a diagram. So this situation, the child is on his back, his head's turned to the left, and we're working on the right ear. and an incision has been made, the ear's brought forward, where the ear should have been is brought forward, and we're exposing the area of the bone where there should have been an ear canal. If you think back to the CT scan that showed where you could see one with a canal and one without, this is the exact case of the one where there should have been a canal, but there was none on the right side. And here's what it looks like under the microscope. That's the jaw joint you see there. And the canal should have been right here, so the bone has just not dissolved. What we do is we use in my right hand here is a drill with tiny bone chips, diamond chips, excuse me, on it that remove bone, sculpts the bone away. And the left side, there's irrigation that flushes fluid or saline through and takes away those bone chips as we're working. So what we do is in the operating room under the operating microscope at high power, that's a 4 millimeter diamond, by the way, right there, the ball on the burr, we start to remove the bone. And going deeper and getting smaller, we come down to the middle ear and the space where the middle ear bones are going to be found. And in this example, you'll see a 1.5 millimeter diamond, so it's very small. And then the suction irrigation allows us to remove that bone dust. And there you see a piece of bone being removed, and the middle ear bones are just coming into view. Next, we'll use the laser to expose the middle ear bones and to free them from their connection to the adjacent bone. And what the laser does is it doesn't cause vibration, it just vaporizes the bone so that we can then free the bones very delicately. And once that's completed, this is what you have. You see in the area, the canal bone has been removed. So we were looking exactly where we looked in the first photo that I showed you. And now the middle ear bones are present. And as you see, I'm going to touch those and they're mobile. That's where the laser was used to free them. The facial nerve is right down there. It's about 2 or 3 millimeters away. And now you see when I touch the middle ear bones, you can tell that the vibration would actually allow them to move for the first time. So we have structurally the opening made, and now we reconstruct or construct an eardrum made of tissue called fascia. The fascia comes from the surface of the muscle above the ear. It's about the thickness of 2 or 3 sheets of notebook paper together. And it is a collagen scaffold that allows the body to heal and to grow into that. It becomes a living membrane just like a regular eardrum, and the middle ear bones are attached to it. What we do then is after the eardrum is in place, we will cover the area with a skin graft just like a normal ear. Now, in times past, we've taken those from the thigh, from the abdomen, and we got this. We saw really thick grafts. We saw one on the bottom there, surrounded by green, is just deep pigmentation. That's one of the better scars, but it just didn't work well. So we came up with a way of taking the skin actually from the surface of the scalp. And what we do is take a very thin layer of skin. You see me removing the hair from it there. The hair follicles stay in the scalp, so we don't transplant any hair to the ear canal. But the skin graft is then placed in the canal and placed in a way that covers all of the area, and we put packing in that allows the body to grow into it, and that skin graft lives and coats the canal just like a normal ear. And you see there, that's the plane. Usually we use, I like about 0.28 or 0.29 millimeters of thickness. And you see the hair follicles down in the scalp allow this to heal extremely quickly. It's wonderful. And it doesn't hurt like the other ones. The other ones were terribly painful. And the other thing is we've never seen a hypertrophic scar in the scalp. I don't know quite why, but that's fantastic. So that's a great advance that we've brought to bear in this situation. This is what the ear would look like in a combined case where there's a sponge where the ear canal will be. That stays for about 3 weeks while the skin graft and the eardrum are healing. And the outer ear scaffold you can see there is coated with the skin and also tissue membrane that you'll hear about from other speakers. And this young man here just finished his cam. He's awake. He's not in pain because we inject around the area completely with a numbing medicine that lasts the rest of the day. So it's remarkable how quickly these guys wake up and how well they do. This is a patient who had surgery about 13 years ago now. And you can see where the pink sponge is, that's the small ear canal coming out just behind. And you can see a C-shaped incision behind that. So what we've done more recently is we now don't make that incision, and we have this scenario where we just make an incision over the ear canal That allows less damage to the tissue around the ear, so their plastic surgeons have a better chance of providing a beautiful ear and to have the tissue that they need. This is the packing that's present. There's a sponge, you saw that from the outside, and then there's several layers of packing with antibiotics in them. And then over the first several weeks after surgery, we begin to remove those. You'll use drops in the ear, you'll keep the ear dry. And what we're doing is supporting that so that the eardrum and also the ear canal skin can become viable and living. And then the middle ear packing will dissolve over several months, and then we'll reach our maximum hearing level usually 4 or 5 months after the original surgery. Now, we found one thing that's really important for us to do is to make something called an ear mold after the surgery before you go home. You see that blue ear mold in place here. And we make it out of a material that fights scar. One of the complications you're going to hear about in a few minutes, in fact, the most common one around the world, was stenosis or narrowing of the ear canal. And by using this mold afterwards, and also a number of surgical techniques which we've developed, our stenosis rate has changed. Worldwide, it was about 30% when I started focusing on this, to now less than 2%. So that's a really nice advance as well. Okay, look at this one, and look at the top left picture. You can see an eardrum, and there's a black dot right in the center of it. And then now switch your eyes to the center photo, and that black dot has moved on the side of the, like in the middle, sort of the eardrum moving to the left. And now move to the right photo, and you see the black dot is actually up on the skin of the ear canal. That's a normal ear, and that's the normal migration of the skin of the canal that starts on the eardrum and comes to the outside. So the ear is a self-cleaning system. The skin graft that we place, we haven't been able to come up with a way to reconstitute that yet. So the skin graft requires that the ear be cleaned by a local ear, nose, and throat doctor with a microscope. You don't need to come back to the U.S. to do that. And that has to be done an average of once or twice a year. So that's something you need to factor in. We see patients who have repair, great hearing result, things are good, and then they ignore that for 2 or 3 years, and then we'll get a call because there's an infection in the ear canal. And our first question is, when did you last clean it? And if the parent says, about 3 years ago, then we know what's going on, because the skin will build up and you'll block hearing, and you'll also get an infection. Simple, easy thing to do. It's easier than cleaning your teeth, but that's a factor in this process. Now, the middle ear bones, you see this one here, are really tiny. They're the smallest ones in the body. And what we found by looking in the ear with a camera over the first several hundred of these that we did is that there's actually an abnormality in those bones that no one had appreciated before. And that happens in about 30% of our patients. Here's a paper that was written by one of our fellows, Ashley Balaker and I, and also Ernan Goldstein, who was a fellow with us as well, that detailed those. If you like to look that up, you can find this here from that reference. And here's what happens is that normally in an ear, this little schematic, is you're looking or driving down the ear canal. The sound vibrations, as you now know, will provide vibration to the eardrum. And then the middle ear bones, the malleus, the incus, and the stapes is the stirrup-shaped bone, vibrate and transmit the sound energy to the inner ear. Well, what we found is in the joint, and tiny, tiny joint, smallest joint in the body, it's about 0.6 of a millimeter, right here, that there was an abnormality. And I'll show you in a couple of videos what that looks like. This next one is actually a normal ear. So you'll see there is the joint, and as we touch that in just a moment, you'll see that the middle ear bones will actually move. You can see where the laser marks have been used to free it. And now you can see that the middle ear bones are actually moving the stapes. Okay, contrast that with this one. You'll see this with that camera that I spoke about. And here's the anatomy. As the facial nerve is there, other parts of the ear are labeled. And what I want you to focus on is the joint that you saw that was normal. Right there is actually fibrous. You're going to get a better look at that here in just a second. So when the middle ear bones are moving, the stapes is really not moving with it, because instead of bone-on-bone contact, there you see it well, there's a little segment of scar. And that is responsible, I think, for the very poor hearing results a lot of surgeons get. They just didn't know that was there. It's really hard to see because it's kind of tucked back under. So with the camera, we were able to discover that. So the next question, fast forward here, is what can we do about it? And we've come up with a number of prostheses that you see here where we can reconstruct that connection. Sometimes we leave the middle ear bones and reconstruct it. Sometimes it's better to remove them and reconstruct it with a prosthesis. And we can sometimes see that on a CT scan, but it's such a small bone, we never really know 100% until we're in the operating room what we're going to face. And some of the patients will have no connection or very poor connection, and we know that that's not going to do it for hearing. So we go ahead and reconstruct at the time of the first surgery. Sometimes we'll see one that's a partial connection. And I've learned that in some cases we should wait and see what we get hearing-wise, because sometimes I've said there's no way that's going to be good hearing, and we do the surgery and lo and behold, it's fantastic. So we wait and see what we get in some cases. And then those are the 6% cases if the hearing doesn't come up as much as we want, where we go back with another shorter procedure to reconstruct that area. And then obviously if the joint's normal, we don't need the prosthesis. So there's sort of 3 categories. Here's some examples of just the micro-incision area, the ones that we have pioneered recently. And let me tell you about a cholesteatoma. And this is a condition where instead of a normal ear canal, if you see on the left there's a partial ear canal that's filled with tissue. And, instead of being bone or opening, that tissue is an enclosed cyst, a skin cyst, called a cholesteatoma. You see me opening it there. And what that will do is that it will grow slowly over time, and it will cause erosion of the bone and can cause erosion actually into the inner ear and or into the brain. Here's a very large one that has developed. As you're looking at the left side, here on the right side is one where you see the soft tissue, the gray density that's starting to erode into the balance canal. And here's one that's very big that has almost eroded into the brain cavity. So these can be really silent. This patient is actually from Australia, and we knew about the cholesteatoma. We saw that on the CT scan. And what happened over time is that it became infected. When a cholesteatoma becomes infected, this is what happens. You get drainage usually toward the outside terribly, and sometimes you'll get actually spread infection into the brain, and meningitis can result. And I like to tell you about this because everyone that has atresia microtia must, capital M-U-S-T, must have a CT scan before the outer ear is done. Every year I get patients referred to me who have had an outer ear placed without a CT scan, and this is one such patient where a cholesteatoma was covered up. And the cholesteatoma with the blue areas, as you can see now, has grown to the point where it's actually draining through the area where there should have been an ear canal, the red arrow that you see. And you can't always tell from the outside. This is a young man who had a cholesteatoma that we removed, and there was no sign on the outer ear. So everyone must have a CT scan is the bottom line of that one. Now, let's move on to our results section. I want to show you what's the chance that we can actually turn that hearing test you saw at the beginning on the left side of the screen as you're looking at it to the one on the right side where hearing is in the normal range. Now, we so far, never get a perfectly normal hearing. We can't achieve what a normal ear looks like, but we can come pretty close. We can get about 90 or 95% of the sound out of an ear. But a child will, for example, with successful surgery, if you put a phone to a normal ear and to the atresia ear, they'll say, yeah, it's just a little softer in the reconstructed one. Nonetheless, that's functional, gives all of the improvements that we talked about, directional hearing and hearing noise. But the chance really varies by what the CT scan shows us. And this is really important slides for you as parents. The higher the score, the more of a chance that we're going to get into the normal range. With a score of 6 through 10, virtually everyone gets improved hearing. But our goal is to get in that gray range of the audiogram that you saw into the normal range. And if you have a score of 8, 9, or 10, then 80% of patients will come into the normal range. Again, the other 20% are improved, but not to normal. And with a score of 6 or 7, 67% of patients will come into the normal range. Those numbers fall off with down in the 4, 3, and 2 scores to less than 10%. So that's the reason that we say we really don't want to do surgery in patients who have a very low score. Let's talk a moment about complications, and there are 6 that we see with any regularity, and here they are. They're infection at the time of surgery. The eardrum can move away from the middle ear bones, and if it moves away and isn't touching them, then we'll see that the hearing drops off again. That can be repaired, but it's a complication. We can see stenosis or narrowing, I mentioned that earlier. We can see injury to the inner ear from the surgery itself or potentially from an infection after surgery. We can see an injury to the nerve, the facial nerve, and that's probably the one that most parents would think would be the worst case scenario, is to go in with a child who has a symmetric smile and come out with one side that doesn't move correctly. And then the sixth one is the skin graft that we place in the ear canal on the eardrum. In a small percentage of patients, we will see that a part of that graft won't heal correctly, or it can be damaged later and has to be regrafted for things to work correctly. These are the percentages worldwide, and these are the percentages that we've experienced in our patients. So in infection, it's really rare to see an infection of the ear canal, which is great. We've had a couple of infections of the microtia repair, the porous polyethylene, and Dr. Reinisch, if he's speaking to you, or Dr. Tahiri, we'll talk about that. We see the eardrum moving laterally now in 3% of patients. I'll show you why we've been able to reduce that. The stenosis, I think, was my most exciting change, because with the mold and with our surgical techniques, it's now, in our last 250 patients, was 1.9% or 2%. Hearing loss is rare. It's less than 1% for us. And to date, we've not had an injury to the facial nerve, whereas worldwide, about 2% of patients, 1 in 50, will have an injury to the nerve. And then skin graft loss occurs in about 1 in 50 patients also. So those are the things that we see. If you add all of those up, it's roughly in the range of about 6 or 7%. A little higher as time goes by, obviously, with things like lateralization or skin graft loss. But we are able to control most of those complications during the time period that you're in our area. We also send you home with an emergency bag of medications, if you will, and I ask you to send us regular email communication. And if one of the things are starting to develop, for example, restenosis, we have medications and a sponge for you to put in to stop that body process. And we've been able to drastically reduce the incidence of any sort of long-term problems with this. But it is important for you to know that every surgery has complications, and those are the ones that we see most commonly. So these are the results in terms of success of getting hearing into the normal range, and you see the number of cases that people have performed. This was a year that I published this was 2009. We're actually nicely better than that now, but we stack up quite well compared to people around the world that do this. Now, there are really 3 new things that we've done. I've mentioned those. I'm going to go through this quickly because our goal is to find a better way to do things. And we've refined this process throughout the years, and I think we've made some fantastic progress. The 3 new surgeries that we've done are the canal surgery before the microtia repair, the combined surgery where we do all of this in one day, and also where we make the tiny incision to make the ear canal. All of those, I think, are fantastic new advances, and this should be the way everyone does this. Stenosis, I mentioned. It's second to eardrum lateralization. And what we do with that is that we actually make a small hole in the fascia graft that we place against the middle ear bones, and we insert a small piece of the middle ear bone through it, so it anchors the fascia to the middle ear bones. That, by the way, is the way a normal ear is made. So what happens is that when a child gets an ear infection later, which they'll do, the pressure from the middle ear pushing up and out on the eardrum, if it's not anchored to the middle ear bone, sometimes it can push it off, and then you get a hearing loss. So since we've been doing the what we call the incus penetration technique, where we anchor it, then that has drastically dropped off. We also mentioned the middle ear bone repair, the skin graft site, and we have a special way of cutting that skin graft, of tailoring to the ear canal, so we use a single piece. Some surgeons around the world teach that you should use a patchwork or a quilt type of strategy where you take multiple small pieces of skin and put it around the ear canal. I've found that that's not the way to do this, so that's decreased the wet ear phenomenon some people will mention. So here's the rank I promised you earlier. What would I want if I'm a dad and I'm looking at this knowing what I know about it? What would I, if I say, okay, I'm really want to, we'll base this on the CT scan, but here's what I'm thinking. First of all, I'd want a score that's a good one, so that we have an option for canal. That is by far the best. It stays there during life. You don't have to use any devices. You get good hearing. You have to have it cleaned every now and then, but that's acceptable to me. Number 2 would be a canal plus a hearing aid. I would do the canal, and I'd even do the canal with a lower score in some situations, the 5 that we mentioned, and use a hearing device in the ear canal. The next one would be the Vibrant Sound Bridge. That's one of the implantable devices that doesn't have anything coming through the skin. And then 4th would be the Baha or Ponto or Bone Bridge. Excuse me. Those are the implantable bone conduction devices that I mentioned with the earlier slides, and you may have some more information from others. So let's look at our scheme now. So we now know that a CT scan at 2.5 years gives us a grade. 1 through 5, we typically go with an implantable hearing device. And grades 6 through 10, that allows us to make an ear canal. And there are 3 different options. One is a rib graft followed by a canal followed by the outer ear reconstruction, or the combined approach. Now, a couple more resources, and we'll be done here, is first of all, our Atresia Repair website has a large amount of data for you, including this talk, if you want grandparents or other people to be able to see it. And it also allows you to contact us for questions, or for us to give you information, or to do an evaluation if you're watching this from afar. Also, Haley, my daughter, and I have recently written a book called Atresia Microtia in Your Child, and this book will give you a large amount of information. It mimics what we've talked about this hour, but it has a lot more in that area, and it's a really good resource for you to evaluate and sort of keep as a repository of information as you go about this process. If your child's 6 months of age, for example, you're making decisions. If your child's 4 years of age, then you kind of need to get on with your decision. So that book will help you to reinforce some of the things that we've talked about. And lastly, if you decide to have surgery in our area, my wife Julia and I have purchased a duplex, a home that has 2 separate homes within it, 4 separate structures for families to stay in, where it's close to our office. It has a playroom, which, as this slide says, is okay for post-op, which means there's no trampolines or anything where kids jump on each other or run around or play rough games, because they have to be kind of chill for a little bit afterwards. So that's a resource that some people really enjoy and don't have to work or worry about the housing as much. We're also able to offer that at a price well below what others in our area have. Now, last thing, if you want to contact us, AtresiaRepair.com is the website, but our email is AtresiaRepair@calear.com, and that's your site for everything. We will send your email to the appropriate person. For example, if you have a medical question, if you have a question for me, it'll go that way. If you have questions about insurance or cost or scheduling or the AM house, all of those go to a different person. But that's the one email that you send this to. We're happy to answer your questions, and I really thank you for the honor of being able to share this with you and for your time. I hope that's helpful, and please let us know how we can be of service to you in the best way possible. Take care. So there you have it. That's a lot of information in a short period of time. Thank you for watching it. Thank you for getting to this point. We may have other questions that we've generated by talking to you, and please let us know if we do. We also are available to you to do a review of CT scans, as we talked about, and to give you a plan. If we can help you, the email that was in the end of the talk is where you do that. You can also give us a call. We look forward to hearing from you if we can help. Thanks.